And I know that you wanted to talk about your sexual health history. This feels like the right time.
So I always say that the greatest thing I've ever had to honestly was working with a young patient population, because like they really broke me down in the sense of like terms, lingo, like everything. And I still learn so much from them. It's a joy taking care of them. I always think there's actually an insert from like the CDC. And it's really thinking about like the 5 Ps. Now, I don't always remember all the Ps, but it's still good. So I think one is like looking at practice. So like, what is their practice? So I usually will go in, like I always start off with like, I have no assumptions. Just tell me like, what preference of partners do you have? Trans, female, bi, overall, how do you practice? Top, bottom, verse. Usually I preface this by, this is important for me to think about for testing. So like I usually will preface that from that. Sometimes I'll even ask them, have they been tested in that modality before overall? I think the next thing I kind of get to is number of partners within the last 3 to 6 months. So again, it gives me an idea of how often to do STD screening. Making sure that that's offered, and then also thinking about HIV PrEP if there's like also partners that they're necessarily having that might be interested in that as well. I think also prior history. So again, knowing if they had previous histories of STDs, mostly to make sure that they get tested more frequently, and then also to make sure that they're getting tested correctly. A lot of times I see the primary care providers, amazing. They'll do a good job of screening. They forget to check syphilis. So like a lot of times I'll see like the urine and the swab, but I won't see the RPR actually. So just there's higher rates of syphilis as expected. And then one other thing that might be a little bit different in my patient population is Hep C. So there's been some data looking at sexual transmission, mostly in MSM. So there's been thoughts that screen Hep C might want to have a discussion with patients to screen yearly, actually. So that might be something else in my practice. And making sure they're immune for Hep B is also a part of my practice. So like looking through all these is making sure that if we do have the swabs to do rectal and pharyngeal testing, that should be included as well, because we'll catch more cases that way. Yeah,
we learned that. We did a STI episode years ago, and I again was embarrassed to not know that. I was just like, do the urine nucleic acid amplification test and I'm good to go. And our guest is like, no, you miss a ton if you do that. Like you have to ask them like, how are you having sex? And then you have to do rectal swabs or pharyngeal swabs, as you just said, as well, if that's happening. So I think that's we can't say that enough so that people remember to do that. What else, Paul?
I wanted to ask about, well, actually, I guess let's get into the labs first. So we have some of these up here. Hopefully they're reasonably accurate, but I guess, now let me go back to my original question. I heard rumblings about doxycycline for sort of STI prep. Can you talk to me, where are we at with that? How should we be thinking about that? Is that something that is commonly used?
Sure. When I was in Philadelphia, there was an arm of the IPRGay study that looked at doxycycline to look at reducing the cases of syphilis and chlamydia. As the advent of HIV PrEP, great in preventing HIV, expectations that there's been higher cases of STD, especially in certain patient populations where there's just much, much higher cases overall. The thought process is that it's really thinking about it like post-exposure prophylaxis, because what they're looking at is providing doxycycline, which is 200 milligrams you want to do it within 24 hours, but up to 72 hours after a condomless sexual activity. And what they noticed is that it actually decreased syphilis cases and chlamydia cases. UCSF in their state health department, I thought, had just come out with a study because it was kind of mentioned in the International AIDS Conference from last summer, actually looking at doxycycline. And they were only looking at it for MSM. So it's only really MSM, it's cis men or trans females to think about when we're talking about doxy prep, actually. And although there's ongoing studies looking at it for cis females as well. But what they noticed was that it reduced STDs, but up to 66%. And as before ID fellowship, I was an epidemiologist, and I can tell you I've never done syphilis contact tracings, but I've done other contact tracings. It takes up a lot of time and resources to really find patient zeros. So like when you're trying to find and track cases of syphilis, how much resources are spent. Thinking about conversations about doxy PEP might be something to actually talk about. And
this is a daily doxy dose
so
to prevent?
There's two different ways. So most ways I've used it is mostly as post-exposure prophylaxis. So 200 milligrams within the 72 hours, really try to put it 24 hours. There's other studies that are coming from Canada and Australia that are both looking at both PEP and doxy prep as well. So there might be stuff coming out because next week is our big retrovirus and opportunistic conference, which is a mouthful. So we just call it CROI. So CROI. So there might be some updates.
By the time this airs, we might have to update the show. You'll let us know if we need to update the show notes by the time this airs.
But the question comes on who to think about it. So when I was in Philadelphia, I remember the health department meeting with us and just talking about how much resources they use for syphilis testing. And there had been discussions and reflections on should we be thinking about doxypep. So it's a conversation that I've had for my patients. I think of any patients that had more than 1 or 2 STDs actually within a year, especially if it was syphilis. Actually, so it's like one of the big things that I have had discussions with. The controversy or the part did not know in that study, the most recent one was there was more resistance to gonorrhea. Like it reduced it, I think, by 50%.
Yeah, we don't want super gonorrhea to get any more prevalent than it.
But the caveat is that we don't really use tetracycline for gonorrhea treatment. But the question is, well, will it change the biome or resistance for other stuff that we use doxycycline for, right? So when we think about staph infections and stuff like that. So I think there's still a lot of data